Good morning, everybody, and thanks for being here early in the morning. I hope some colleagues will join in a while. I hope yesterday enjoyed the meeting, and today we have a quite tight schedule, so we are starting very sharp, 8:30. And so we start with the first session on cardiac amyloidosis, and it's my pleasure to introduce the chairs for this session, who are Dr. Basic from Gothenburg and Dr. Lindmark from Stockholm. Please.
Good morning, everybody. Thank you very much for having us. We will have three excellent presenters today. And if you have been to any cardiac convention recently, you probably think that cardiac amyloidosis is the most common cardiac disease. It actually warrants more attention, and I would like to leave the word to my co-chair, Dr. Basic.
Yes, good morning, everybody. And as you said, Christer, this is a diagnosis that is raised a lot of interest last few years, and definitely it was motivated because still we have many unmet needs regarding this diagnosis. And one of those is how to recognize the patient with cardiac amyloidosis. And this is the first topic of our session today. And let me introduce David Stofolo from Italy, who will be taking us through this topic.
Thank you, Chairman, colleagues. It's a pleasure to be here. I would like to thank Gianluigi and Frieder for the invitation. I apologize for my very sensual voice. And so the problem of cardiac amyloidosis is a growing topic because, as we already said, the attention for the disease has increased in the last year, and this caused an increase in the number of diagnoses, as you can see here in this epidemiological study, and also a change in the proportion of patients with the two main forms, AL, that still remains the most frequent form of cardiac amyloidosis, a TTR amyloidosis that is increasing because with the advent of novel drugs, we have a different attention to the disease. This is not just a matter of cardiologists, because other specialists that are involved in the care of patients with potential amyloidosis increase the referral rate of the patient to the tertiary care center for the management of the disease. So the attention is getting higher, not just for the cardiologist, but also for the other specialists. If we have to think how to recognize a patient with cardiac amyloidosis, we have to mention echocardiography, because for a long time it has been the milestone for the diagnosis of the disease with very traditional parameters like right ventricular hypertrophy or the thickening of the atrial septum and the atrioventricular valves, or the granular sparkling aspect, or more novel parameters like the apical sparing pattern at the left ventricular speckle tracking analysis. But things are changed because now we have to count on a different approach. The non-invasive diagnostic approach of amyloidosis count on paradoxically two non-cardiac tests, bone scintigraphy and hematological test. And the combination of these two allow to achieve the diagnosis of the disease in most of the cases. In particular, when we have a TTR cardiac amyloidosis, we don't need histological confirmation anymore if the hematological tests are negative. And so we need, thank you so much. Thank you, sir. And so we need, we need histological confirmation only when the hematological tests are positive and the scintigraphy is negative, or the pattern is typical of AL cardiac amyloidosis. The possibility to count on a non-invasive approach increased the number of cases of disease, but also allowed physicians to have more earlier diagnosis, and in particular, patient can present with less severe HF phenotype, and this translates in a better outcome in the long term. Another important point, I think, is that patient can obtain a diagnosis of amyloidosis passing through a different diagnostic workup, because within other phenotypes of cardiac disease like HFpEF, hypertrophic cardiomyopathy of aortic stenosis, it is not infrequent that patients can present a cardiac amyloidosis at the end of the diagnostic workup. In this review of screening studies, 10% of patients with HFpEF, HCM, and aortic stenosis at the end had cardiac amyloidosis. Aortic stenosis is the most widely recognized disease that is frequently combined with cardiac amyloidosis. In a cohort of patients that are referred for TAVI, so for valve replacement, 15% of patients had concomitant cardiac amyloidosis, and there is a score available that can allow to define the diagnosis in this patient in order to handle also the other diagnosis, not just the valve disease. The way the patient achieved the diagnosis of cardiac amyloidosis can affect the outcome. This is quite obvious. If a patient is diagnosed because of imaging incidental findings or clinical sign different than heart failure, the outcome is different than a patient presenting with heart failure, because heart failure in cardiac amyloidosis is a marker of very advanced disease. The same consideration can be made for another tool that has been considered a milestone, a cornerstone for the diagnosis of the ECG. We were used to think that low voltages at ECG were a marker of the disease, but instead they are a marker of an advanced disease. So in presence of low voltages at ECG, the prognosis of the patient is worse, and in particular for patients with AL amyloidosis. So we have to be ready to define the possibility that the patient can present with amyloidosis also in presence of normal or relatively preserved left ventricular ECG voltages, in particular if there is a discordant ratio between the ECG and the severity of the left ventricular hypertrophy. Earlier diagnosis means better outcome. It is demonstrated that with the increased awareness of the disease, the proportion of patients that diagnosed earlier in terms of stage of disease is increasing, and this translates in a better outcome in the long term. So our task is to achieve a prompt diagnosis of the disease. But it is never too early, because also for patients that are asymptomatic for heart failure, it is well demonstrated that patients with a very positive scintigraphy have a very higher cardiovascular mortality rate compared with patients with only mildly positive scintigraphy. So we need markers of early disease. Cardiac biomarkers were considered, NT-proBNP and troponin, as potential markers for the rule out of the disease because they have a very high sensitivity. This is true, but it's also true that nowadays, with the increasing rate of diagnosis of very early stage, there is also the possibility that patients can present with normal biomarkers. We'll see this later. So probably we have to find early marker of disease outside the heart. The extracardiac manifestation of cardiac amyloidosis can help us in the identification of the disease in a very early stage before the involvement of the heart can present with overt clinical manifestation. And among all the potential extracardiac manifestation, the carpal tunnel syndrome is the more widely known disease that is frequently associated with cardiac amyloidosis, and in particular for the transthyretin form of amyloidosis. 10% of patients that are treated for CTS, idiopathic CTS, present at a histological sample some deposit of amyloid. And in this very nice study, patients that underwent surgery for bilateral CTS were offered to be screened for cardiac amyloidosis 5 to 15 years later. You see, 5% of the patients received a diagnosis for cardiac amyloidosis, but the rate increased above 20% if we consider males over 70 years of age and with a BMI below 30. Of course, advanced imaging is essential for us. Scintigraphy is a confirmatory test for the diagnosis of TTR amyloidosis. It is also important to remind that with very positive scintigraphy, we don't need histological confirmation. For mild positive scintigraphy, we need histological confirmation, endomyocardial biopsy or extracardiac biopsy, and that also for AL cardiac amyloidosis, about 40% of patients can show some amount of cardiac uptake. MRI is as well essential because it has multiple markers that are very typical of cardiac amyloidosis that are summarized here on the right upper side. And this is also important because sometimes it leads to the diagnosis of cardiac amyloidosis for patients that were undergoing a workup for different potential disease, like for instance ACM or other non-hypertrophic phenotypes. So it is not infrequent that we have positive MRI for patients that at the initial stage were not suspected for having cardiac amyloidosis. When we have the diagnosis of TTR cardiac amyloidosis, all the patients should be tested for genetic mutation. This has important implications for the clinical management, but even more probably for the family counseling. I would like to conclude with a case, a very brief case. I know that Antonio will show you many cases later, but I think it is the paradigm of what we are going to deal with in the future. 55 years old male with only mild to moderate left ventricular hypertrophy. It was admitted for syncope, no other symptoms, no heart failure. Everything was normal, not intolerant to medication, normal biomarker, only a history of bilateral CTS. He underwent in the diagnostic workup of syncope MRI. It was very suspicious for amyloid. The scintigraphy was very positive, so he received a very early diagnosis, also in terms of age, of wild-type TTR amyloidosis. So I think we can make the difference not just with novel drugs that are going to change the natural history of this disease, but also if we are able to achieve a diagnosis in the very early stage of the disease, the prognosis or the perspective of our patient will change in the future. AI will support us probably in this task because we have multiple studies proposing tools for early diagnosis of amyloid. This is only one example of a screening tool that, starting from a single 4-chamber apical view, can provide a very high rate of probability of diagnosis. I think this in the future will support physicians in our mission of having early diagnosis of this disease. Thank you for your attention.
Thank you. Thank you very much. We'll leave the questions for later for the discussion. So we'll move straight to the next presenter, Professor Peter van der Meer from the Netherlands. He will talk about actually the reasons why we all talk about it during the cardiology conventions, because there are so many therapeutic options already here, and there are even more coming up. So we're delighted to hear about that.
Well, thank you very much for the invitation to speak here. Yeah. Do we have the slides? Yes, we have the slides. So thank you very much to be here in Stockholm. So here are my disclosures. I think also in the previous case, this is where we all do it for. This 76-year-old male coming in with New York Heart Association functional class 3, very thick ventricles, the typical cherry on top with GLS. And I think also what we've previously heard, a very important tool to make the distinction. And here you see the bone scintigraphy tracer uptake. And what we also heard, it is not that uncommon to find a disease. So this is, for example, one of the screening studies, almost 300 patients in North America. All patients got a bone scintigraphy if they were aged older than 60, had a diagnosis of heart failure and an ejection fraction of more than 40%, and not so thick walls. So if the walls were 12 millimeters or higher, then they were referred for screening. And here, as you can see, around 7 to 8% of the patients, they were diagnosed with ATTR. All of them were wild type. So it is not that uncommon if we look better in our especially patient population with heart failure and preserved ejection fraction. But let's change gears and talk more about the treatment. And I think when you think about the treatment for ATTR, you can really divide them in 3. So on one hand, here on the left side, you have the silencers, the CRISPR-Cas therapy. So this is really the part where you let the liver stop producing TTR. And I will come back to all of these treatment modalities you see here. And then we have also, because when does the disease get into trouble? That is because when the pentameres really fall apart into monomers. So we have these stabilizers. So there are currently 2 stabilizers which are AMA improved. It's tafamidis and acoramidis. And I will also show data of that. So this is stabilizing the tetramers. And when you stabilize the tetramers, it does not fall apart. And when it does not fall apart in these oligomers, the fibrils are not being formed. So that's the principle of the stabilizers. And then the last part, part, the newest kid on the block, so to speak, is if you think about the patient we saw in my first slide, with these very thick walls, 25 millimeters, of course you can stabilize it, but the patient will still have a lot of symptoms. What about if we can remove it? And these are the newest trials which have been published. So this is how everything started. This is the ATTRACT trial with tafamidis, the landmark trial, the first outcome trial in patients with amyloidosis. So it was a mixed bag of patients with wild-type TTR and hereditary TTR. And here you can see it was a pooled group. It was a low dose of tafamidis, 20 milligrams and 80 milligrams. They were pooled together because there was no heterogeneity, and it was compared with placebo. And here you can see all-cause mortality. So it was a hazard ratio of 0.7, so almost an absolute risk reduction of around 15%, so leading to a number needed to treat of 7 for the duration of 30 months to prevent one death. And I think in some countries it led to some discussion, like if you have very advanced disease, because you see the curves separate only after 18 months or even later, around 18 to 19, 20 months. Here you see the curve separate. So what about if the patient has very advanced disease? Does that patient have enough time to live before some effects are being seen? And that, for example, in the Netherlands led to the insurance companies that they will only reimburse tafamidis if patients are in functional class 1 and 2. Personally, I think that's an overstatement of the data, but it is what it is, and that has to do because the drug is very expensive. But you can see that not only the effects on mortality appear somewhat later, but here you can see the change in 6-minute walk test, and here you can see already a very early separation of the curves between patients treated with tafamidis versus placebo. Relatively sick population with an NT-proBNP of 3,000 median. And you can see later trials, and I think that really has to do with better screening. We identify the patients in earlier stages. So typically what we see now in most of the amyloidosis trial, that the median NT-proBNP is around 2,000. So this is a very, very sick population. And you can also see here in the placebo group, around 40% mortality within 2.5 to 3 years. So very, very sick patients. This is the other stabilizer, a trial which came a little bit later. It's the ATTRibute trial. It was done with acoramidis. A similar kind of setup, acoramidis versus placebo. It binds to a slightly different spot in these tetrameres and leads to stabilization. So slightly different than tafamidis, but similar principle. Prevents the degradation, and that prevents the formation of fibrils. It was a win ratio. More and more we see win ratio. So it's a composite of endpoints. So here you can see the win ratio. It was not only cardiovascular mortality, cardiovascular hospitalization, mortality, and NT-proBNP. You see a clear win there. But also if we look only for the harder endpoints like cardiovascular hospitalization or mortality, also there is a win. And here is how the curves look. For example, here you can see more the quality of life, also early separation of the curves there, the 6-minute walk a little bit later, where the differences start to kick in after 1.5 years. And here you see the mortality, which did not meet statistical significance, but the curves are somewhat similar to what's also been observed with tafamidis. So these were the stabilizers. So what about the silencers? So there are 2 ways these silencers can work. So it could be an RNAi. So most trials has been done with siRNAs. I will also talk about the Helios B. They used an siRNA, but there are also antisense oligonucleotides. More or less a similar principle. The RNA is being degraded, but if you have an ASO, they will move into the cell. There's hybridization, and the body doesn't like to have hybridized RNA, so immediately the RNAs will kick in and will just cut it apart. Whereas for the siRNA, the risk complex is involved, and at that stage, the risk where the risk complex is, there will be cutting of the target. But the eventual result is the same. The protein is not being expressed. This is the landmark trial with the silencers. It's the drug is vutrisiran. It is EMA improved. I think in many countries it is already available for the variant ATTR. I think many countries there are now also negotiations with the Health Institute about reimbursement costs, etc. Similar kind of setup. So the patients randomized to vutrisiran, a little bit more than 600 patients, as you can see here, and near the placebo group. I can't really read it from there, so I don't know it by heart. But yeah, the average age is 77, 76, as you can see here. Almost all, like more than 3/4 of the patients were in functional class, where is it, functional class 2. So clearly less sick than the patients from the tafamidis group. And as you can see here, the NT-proBNP is around 2000. Clear effects here, you see time to first event in the overall population. Cardiovascular hospitalization or mortality, hazard ratio of 0.72, and here you can see the death from any cause, so all-cause mortality, very nice effects as you can see here, a separation of the curves within 2 years, with an absolute risk, absolute difference from around 15%, so very important data. And here you can see like the overall population. So why did they mention specifically the overall population? Well, it's because like more than 40% of the patients were also using tafamidis. So this was also in patients who were already on background therapy with stabilizers. So in a large proportion of patients, it was on top of these stabilizers, and there was no clear heterogeneity there. The effects seemed to be a little bit bigger if patients were on monotherapy. So if they were only using vutrisiran, but also in patients who were yet already using stabilizers, there was a significant effect there. So important trial. So how can we explain it? This is a sub-study which appeared in Nature Medicine this year, looking at echo data. And as you can see, there are differences on wall thickness, as you can see here, modest effects there, preservation of ejection fraction, better preservation, and here also the global longitudinal strain, significant differences there. But I think we need to be realistic that the effects are modest. Like there was a 0.4 millimeter difference in wall thickness between the placebo and the intervention group. So no large differences there. Although with these soft endpoints, it's always difficult if patients already died, for example, in the group who have been treated with, who were in the placebo group. These are the worst patients, and they don't show up here at 30 months for the echo. So some problems always with these soft endpoints. This is another drug. It's a CRISPR-Cas. So for you, probably you know the CRISPR-Cas. The Nobel Prize was given to the inventors of the CRISPR-Cas. It's a very innovative technique. It also targets the liver. So for a CRISPR-Cas, you need the Cas molecule, which actually does the cleaving, and you need a guide RNA, which actually guides the Cas to the right spot. So you have this guide RNA. So everything is being put in a lipid nanoparticle. So the Cas and the guide RNA, and the guide RNA specifically recognize the TTR here, and then the Cas is actually cleaving it. So it's actually, you cut completely TTR out of the genome. So this is not RNA, so this is DNA editing. So you cut the TTR gene in pieces, and it's not being transcribed anymore. And you can see here, this is a phase 1 study, 36 patients. 1/3 had VATR, so the variant form. Mostly were quite severe with functional class 3. No patient was using tafamidis or silencers because the study was executed in the UK, and tafamidis was at that time not available in the UK. And here you can see the TTR level. So in the serum, you can measure the TTR, and you can see there is a very sharp decrease in TTR. So almost a 90% reduction in your TTR levels after very, very soon after you administrate the CRISPR-Cas lipid nanoparticles. So very effective. However, because based on these data, there was the phase 3 trial was started, the Magnitude trial, and that was unfortunately put on hold because there was one patient who developed very severe liver toxicity with AST values like 1,000 times the normal value. So you talk about AST values in the thousands or 10,000s. That patient eventually also died. So that was the reason for the company and also the FDA to put a hold on the trial. And currently it's being investigated, this case, and if there are more cases, and how that should be solved, of course. And clearly the treatment is in the liver with this CRISPR-Cas. So somewhat concerning, and we really need to see how that will play out in the future. This is the last part. So we had the silencers, we had the stabilizers, and here we have the removers. This is a trial we conducted in 3 countries in Europe, where an antibody was actually designed by Neurimmune, which is the company who made it, and that antibody exactly recognized the amyloid fibrils in the body. And here you can see it's somewhat a difficult design. So there was a 4-month placebo-controlled trial, so a high dose, a low dose, or the placebo. And then eventually after 4 months, everybody switched to the active treatment in somewhat lower or higher doses. And then it was extended. And here you can see, for example, the effects on the bone scintigraphy tracer. Here you see the baseline. And after 4 months of active treatment, there was a clear reduction. And that persisted over time. And here you can also see that the patient who was firstly randomized to placebo, there was no difference in the first 4 months, but then after moving to the active treatment, there was also a regression there. So very exciting data. I think this is the longer term follow-up, and then I'll finish. Here you see a clear reduction in your also in your ECV, also longer term, so things which typically is not observed in patients. And you see also a clear regression of your left ventricular hypertrophy. So really a treatment which is improving also functionally the heart and leading to wall reduction in wall thickness. And this is the second study. Novo Nordisk did a similar trial, phase 2. No effect on 6-minute walk, but a clear effect on NT-proBNP. So to conclude, I think ATTR is a relatively common cause of HFpEF, highly dependent on age and sex. TTR is, I think, a very good example of precision medicine in heart failure. Several phase 3 trials showed benefit for stabilizers and silencers. And although attractive, I think there are some safety concerns right now with CRISPR-Cas. We'll see how that plays out. And I think antibody treatment, especially for the patient with advanced disease, I think is promising. And hopefully the phase 3 trial would show beneficial effects there. I thank you for your attention.
Thank you very much. Now, let me introduce the last speaker in this session. This is Professor Antonio Canata from United Kingdom, who will take this into a clinical perspective.
Thank you. Good morning, everyone, and thank you for being here this morning, and thank you for the very nice presentation. So the task today has been given was to try to translate what we've just heard from a more scientific point of view into what we actually see in clinical practice. I might say that my full disclosure is that I'm a little bit jealous because when we were listening to the other two presentations, there are so many tools that you can actually use. And in clinical practice, what we do, at least in the UK, we don't have that many options to be used except in one just golden place. So how are we gonna try to see what we actually see in our daily practice? I think that cardiac amyloidosis is a little bit has a game of shadows. For those who like films, it's Sherlock Holmes. And for those who like a little bit more literature, is the portrait of Dorian Gray from I'll tell you later. So where do we start? So let's start with two different patients that they come to the attention of the primary care physician. We have David on the left side and we have Michael on the right side. Both of them, they have exactly the same age. They're 79 years of age. They come to our attention because they have shortness of breath. So they come with symptoms of heart failure, they are breathless on exertion, and they go to the GP. The GP usually starts with a physical examination and they do some blood test. And the blood test shows that the NT-proBNP for David, it's 2,300, and the NT-proBNP for Michael, it's 1,400. So what's next? The GP start asking some questions, and just to recap, we have signs and symptoms of heart failure with elevated natriuretic peptide. And for David, we have a past medical history that is quite suggestive because the patient has a bilateral carpal tunnel. It was very well known to the medical community because in the past he had some episodes of anemia. He went an OGD, he went a colonoscopy, and they found some arterial malformation in the large bowel. And he also was known to the cardiology department because he had a history of paroxysmal atrial fibrillation, and he already underwent a couple of DC cardioversions, so we already knew the patient quite well. Michael, however, was a builder. Now he's retired. He was previously fit and well. He had a history of hypertension on amlodipine, which is maybe the most prescribed antihypertensive drug. And he also has a history of paroxysmal atrial fibrillation, mentioned somewhere in his medical history, but never been shown on an ECG, at least not that we have found. So in the pathways of care of these patients, the NICE guidelines suggested that patients who have signs and symptoms of heart failure, and they do have also an NT-proBNP, they got referred to an heart failure clinic, and they have to undergo an ECG, an echocardiogram, and to be seen by a cardiologist. So we brought this patient in, and we booked an echocardiogram. David has a normal echocardiogram from what you can see from the report. We read the report. There is a normal left ventricular size. There is a little bit of increase in wall thickness, just 16 millimeters. The ejection fraction measured by the 3D is absolutely fine, it's 60%. There is a normal right ventricular size and normal right ventricular function. There is a bit of mild bilateral dilation, but nothing massive, and the valves, they're absolutely fine, and there is no pericardial effusion. Same for the echocardiogram for Michael. Please accept my apologies if he's going from a 5-chamber to a 4-chamber, this loop. Is a normal left ventricular size. There is a bit of increasing in wall thickness, 17 millimeters in mean wall thickness. The 2D Simpson left ventricular ejection fraction was measured at 55%. Again, here, normal right ventricular size and function, and bilateral dilation, just a mild bilateral dilation with no valve abnormalities. So what are we going to do next? For David was a little bit more intriguing because he had a history that was suggestive that something was going on even before his actual presentation. So we had a bit of a discussion with our colleagues and the nuclear colleagues. And we thought that in this case, we could have done a bone scintigraphy. And indeed, we did a bone scintigraphy, and he came up with a Perugini grade 1. We also did more detailed blood tests, and we've seen that the kappa and the lambda, and especially the kappa lambda ratio, were overall within range. They were not strikingly high, and there was no serum or urine immunofixation. So at this juncture, we then wanted to move a little bit forward. Instead, for Michael it was quite easy because we had a suspected diagnosis of HFpEF. We have signs and symptoms of heart failure. We have elevated NT-proBNP. We have a normal ejection fraction with potentially a little bit of atrial dilation and a little bit of wall thickness. So we calculated these amazing scores, and we do have the HFA-PEF that has 7, the H2-PEF that is 5, so there is intermediate to high likelihood of HFpEF. When we do the ABA score, there's 95% of probability that this patient has HFpEF. So I think that we were all clear that this patient would have HFpEF. So we started the treatment with furosemide, with apixaban for the paroxysmal atrial fibrillation, an SGLT2, and we kept on with the amlodipine, and then we sent back the patient to the GP. For David, instead, there was a little bit more of a discussion, and given that we are approximately at this stage, so we have a bone scintigraphy with a grade 1, we don't have evidence at the blood test of or the immunofixation. So we wanted to have a better understanding. So we sent to have a cardiac MRI. And the cardiac MRI shows that there is an interventricular septum of 19 millimeter, small crypts within the basal infralateral wall. And there was a patchy mid-wall and subendocardial LG in the context of left ventricular hypertrophy. The person who reported the MRI says this is compatible with hypertrophic cardiomyopathy. So this patient was labeled in another center as having an HCM. 3 months later, he comes to our hospital, he gets hospitalized for fast atrial fibrillation, and he gets DC cardioversion. He gets then discharged and seen in another center. They do echocardiogram, 51% of ejection fraction, increased septum wall thickness, there is a mild matter regurgitation, and they found an LVOT gradient during Valsalva of approximately 20 millimeter of mercury. He also does a 24-hour tape, but there is a short run of non-sustained ventricular tachycardia. Someone comes up and saying, well, let's calculate the score, the HCM risk score, it's 4.3%, ICD may be considered, why don't we give him an ICD? Fortunately, the patient refused to have an ICD implanted in primary prevention, and it then came back to our center. We see them both on the same day, David and Michael. So in our routine follow-up, they both have mild peripheral edema. The ECG of David shows a sinus rhythm with a first-degree AV block and left axis, not atrial deviation, with a bit of left ventricular hypertrophy. These are his blood tests, and these are his medications that were prescribed in another hospital. Michael instead has still mild peripheral edema. The ECG is overall unremarkable. He is on furosemide and apixaban, and he had discontinued the SGLT2 because he had some urinary tract infection and trash, and discontinued the amlodipine by the primary care physician because it was not more needed because the blood pressure was cured. We do our repeat echocardiogram. This is the echocardiogram of David, which again is a 79-year-old with hypertrophic cardiomyopathy at a cardiac MRI. And the echocardiogram shows the 60% of ejection fraction, a septum that is 17 millimeter, a bit of atrial dilation, and there is a reduced atrial strain with a mild to moderate mitral regurgitation. Michael, instead, was a 79-year-old with heart failure and preserved ejection fraction. Again, the ejection fraction at the echocardiogram is 55%. Still, we have a bit of hypertrophic interventricular septum and a mild mitral regurgitation. When we did the strain, the global longitudinal strain, this was the appearance of the GLS at this echocardiogram. And when we did the strain also to the echocardiogram of David, this was the appearance of the strain, and there was also an EF over strain ratio of 6, which is highly suspicion of infiltrative disease. So just to recap, we have David, that is a 79-year-old with hypertrophic cardiomyopathy at cardiac MRI, and Michael, who is a 79-year-old with heart failure and preserved ejection fraction. However, we look at David, there are some red flags. So there is a carpal tunnel, he has atrial arrhythmias, elevated NT-proBNP, left ventricular hypertrophy with apical sparing. There is a granular sparkling at TTE, and we did an abdominal fat pad aspiration, which, however, was negative. And Michael, instead, when we actually look at him, he had a big tongue. He also has atrial arrhythmias. There was a reduction in the antihypertensive medication, and the appearance at the ECG was quite suggestive. So for Michael, we did a cardiac MRI that then confirmed the diagnosis of cardiac amyloidosis. However, what about David? David was then readmitted for an atrial tachycardia, which then spontaneously reverted, and we performed an endomyocardial biopsy. These are the appearance of the endomyocardial biopsy. We can see that there is a presence of diffuse amyloid inclusions. The Congo red, which is the bit one here, is definitely positive. We also done an immunohistochemistry, was positive for anti-TTR, and also there is birefringence in the apple green light, in the polarized light. So just to recap, both of them, David had an hypertrophic cardiomyopathy mislabeled, and instead he has an ATTR cardiac amyloidosis, and Michael had HFpEF and now has cardiac amyloidosis. What to do next? What are we going to do? Tafamidis of vutrisiran. This is just from the Peter's talk beforehand. These are the main two registratory trials that they introduced these two drugs in clinical practice. But why I was saying that I was a little bit jealous, because at the moment in the UK we could only prescribe the tafamidis. But just a couple of days ago, we're going to be allowed to prescribe also vutrisiran, except for the compassionate use. At the moment, only some specific places they can prescribe, not all the places. We are trying to implement also in other hospitals, except for the National Amyloid Centers and in large tertiary centers. But usually we refer this patient for the treatment, and especially for compassionate use, to the National Amyloid Center. But these are my take-home message. Just be aware of easy diagnosis. All the diagnoses, especially in patients with preserved cardiac function, they're a little bit more complicated and require a multidisciplinary approach. It's very important to recognize potential mimickers and always talk to the patient, because that's very important. Thank you very much.
Thank you very much. I would like to first apologize, because we have a third chairperson who's with us online, Professor Patel from India. I would like to leave the word to him for a minute or so. Welcome, and
Hi.
apologies for not introducing
Good morning,
you
all.
earlier.
So good morning, all. It was a wonderful session. Thank you all the speaker for a wonderful presentation. Regarding the first presentation, regarding the clinical diagnosis of amyloidosis, I recently came across a patient who is an NRI from India who resides in US, a 78-year-old, absolutely fine, but only complaints were effort breathlessness, and which is progressive in last 1 month. He came in India for a visit for a family. He is a diabetic, stage 1 hypertension, taking just 2.5 milligrams of amlodipine. He's already on empagliflozin for his sugar management along with metformin. And when he came for a follow-up, and when I checked him, there was a ECG which was a history of left ventricular hypertrophy. I did an echo and it showed a LV thickness of 25 millimeters. So it was quite significantly hypertrophied myocardium. And for a hypertension, which is just a 2 years old of 2.5 milligrams of amlodipine, with dilatation of left atrium and right atrium with mild regurgitation, NT-proBNP was done and it showed to be around 1500. And I could able to diagnose it as a HFpEF initially, and then further evaluated by doing a cardiac MRI. And to the surprise, the cardiac MRI showed a late gadolinium enhancement, which was circumferential, and it was like more than 55% of myocardium was LGE enhanced. So there was a strong suspicion that this could be a hypertrophic cardiomyopathy. But then this was because ECG was showing left ventricular hypertrophy, and I was not very keen of amyloidosis because we usually say that there will be low voltage complexes in precordial leads, especially limb leads rather than a precordial lead. But then in this patient, it was more of a left ventricular hypertrophy. So it misled me initially, but then as we went forward, we did light chain, and then it turned out to be ATTR wide. Just to conclude here, ECG could be misleading, and AL type will usually have low voltages. ATTR may not have low voltage complexes, and we should not just looking at ECG should not miss out amyloidosis. It's very common nowadays, and we also diagnosed in India a lot of patients with amyloidosis, and tafamidis was started for that patient, and he's now doing very well. There was hardly any conduction abnormality, and or after 1 month's time, patient says he's slightly better, and he went back to US. So this is what about the case. I think ECG sometimes can mislead you. After going through literature, it tells me that 50 to 60% of AL type will have a low voltage. 20 to 40 will with ATTR will have low voltage. Especially wild type will have slightly better low voltage compared to the hereditary type. So hereditary type can be missed with normal ECGs most of the time. Over to you. Thank you.
Thank you very much for illustrating this diagnostic challenges. And when we are talking about this, is it time to screen patients in specific populations? If I may raise the first question.
Yes, we have also Dr. Eldhagen here and Dr. I'm sorry,
Jardi, yeah.
Inchardi, sorry. Here also, so we have 5 excellent discussants here. And we'll start with a question for Dr. Basic, and then we'll leave the floor up for questions.
Yeah, I don't know if you want to.
Yeah, I don't know if you are ready to start with screening, because I mean, starting with screening, extensive screening program for a rare disease, I think is not affordable for the community. It's different to think that we have to be very ready to identify, as Antonio said, early markers of disease, and in patients like patients with that are treated in the younger age for CTS, for instance, to think about potential diagnosis, underlying diagnosis, so don't overlook early signs of early markers of this disease. start screening programs, I think at this time is not feasible for me, in my opinion. I don't know what Antonio and Peter think.
Yeah, I do agree. It's rather than screening, it's important to think about it when we see the patient. Because if we screen the entire population, we have no idea. Knowledge is not always is a good thing, because you might screen everybody and then what you do with that information. Instead, if you start thinking about potential cardiac amyloidosis when you see the patient, then at least you exclude it and you don't miss it.
I agree with that. With a screening program, you would likely find a lot of indolent or preclinical stages, because the methods we use are very sensitive and we don't know exactly how long the latent phase of this disease is and when to start intervention. Even if we believe intervention at an early phase is the best, there will be costs associated that we are not ready for.
Yeah, and if I just may just add, even if you screen and you do a genetic testing in all of them, we have 2 VUS mutation for both of those patients, so that doesn't really help you in understanding what the patient has. You have a VUS mutation, what can it mean?
Yeah, I think your point is key, because we actually don't know the length of the natural history of disease. We are used to meet the patient when we are used to meet the patient when they already had heart failure, but the feeling is that before that, the history of the disease is quite a long-term story. And the case of this 55-year-old man that received a diagnosis of wild-type TTR is, I think, an indicator of this, because probably this patient for the next 5 to 10 years will never present any sign of heart failure. So we encounter the disease incidentally. And we don't know how long it will take to present with over manifestation of heart failure. So if this is the point, also to set up extensive screening program, I don't know if it's going to pay.
But with that said, I think disease awareness in the heart failure population is very important. And I missed one thing in the case of the ECGs. Would that have helped in understanding?
That was deliberate missing, because if you've seen the ECG, especially for the hypertrophic cardiomyopathy case, you would have said that this is never an hypertrophic cardiomyopathy. So I think it was a deliberate missing, otherwise that would have been too clear early on.
Understand.
I just want to point it out that, the screening program or whatever, it applies to any sort of cardiovascular disease. If you think about atherosclerotic cardiovascular disease or AFib, we cannot afford the possibility to screen everybody. But at the same time, there is a problem of treatment, because oftentimes we get the diagnosis when it's too late. So we are in a moment when we have to find the right time to diagnose and treat, especially because, we are thinking always like a heart failure specialist when all the clinical trials showed like an immediate reduction of mortality or hospitalization for heart failure. This is kind of true for heart failure hospitalization now with the new drugs, but not for mortality. So if we think about having a patient with a diagnosis that is too late in the course of the disease, probably this patient will not take the advantages to take the medication. So the problem, I think, yet is to make clinicians aware of the red signs, red flags that we oftentimes have, but we are not really looking for it. We just take care of, AFib, or we see just the EKG without paying attention, on the small voltages, for example, the Q waves. There are some, opportunity to do the diagnosis, but we don't. So I think that like a community, we still have to push and to make clinicians aware of the opportunity to make the diagnosis. And probably this is just not only for cardiologists, but also for internal medicine, for example, or, for nephrologists, or for, the real problem, and this is a question for everybody, this is something that should be treated and discussed just within cardiologists, or probably we should think about like a multi-specialist, hospital setting to improve the diagnosis of patients admitted to the hospital?
Thank you. Do we have any questions from the floor? Go ahead. Do you have some of the uttermost experts in the world here? So. The big problem for me, oh, sorry, go ahead.
Now, one question that is, again, linked to the screening is the genetic testing in those with the hereditary forms. And we've live in, in the UK, we have the two forms are highly genetic, determined, the Caribbean and the Irish. And the problem is what to do with the young siblings and of those patients. And at the moment, we don't have a clear idea what is the right step in terms of timing. And often we discharge them to the GPs that then will keep referring them every year for a screening. So I think that is how to balance the genetic testing and screening in the families with the capacity.
So Giuseppe, that's a very good point, of course. And just to, well, since my topic was more talking about the trials, there is currently with the acoramidis trial, there is the ACT early trial where patients with variant ATTR can participate. And with so if you know the family, you know the mutation, you get an idea when typically the first symptoms do start. So that's what we use also in that trial. So with this specific, so it's the predicted time of onset. And then we have a time window between 5 and 10 years before that. A patient can, for example, participate in that trial. But I fully agree. I think we are also quite conservative in actually what we're doing to have them back every 1 or 2 years, even longer before that. Yeah, it's a balance, but I think it's very close to patients with DCM in the family where you do some screening. And I think there are some suggestions to do it every 2 years. Some are saying every 5 years, and the truth might be somewhere in between. And for example, in these cases, you don't need to do bone scintigraphy all the time because of course it also is radiation. Troponins are also very sensitive for that if you have no other reasons why the troponin would be elevated.
Yeah, I think that just want to add on this comment, as compared to other cardiomyopathies or in general, we have a very strong specificity or sensitivity of BNP and troponin. So if we think about genetic mutation, positive genetic mutation in a patient without any signs of LV hypertrophy, we can just keep following that up with biomarkers. I'm really, confident that a patient with a mutation with 100 of NT-proBNP doesn't really have anything. I don't need to test every year to do scintigraphy or echocardiogram. BNP normal, troponin normal. It's pretty normal, I would say. So I think we have the opportunity to follow up this patient without even, inpatient visit.
If I may, there are a couple of differences, I think, with cardiomyopathy. The first is that the feeling is that the velocity the disease come up is quite slower compared with other cardiomyopathies. The natural progression of disease is lower. So, as Peter said, we can be a little bit more conservative, and there's not the same sudden risk that we have with cardiomyopathy. The risk of sudden cardiac death in cardiac amyloidosis is relatively low. So we are not afraid as for carriers of mutation of cardiomyopathies of presentation with major arrhythmias. These are two potential differences in the screening program we have to take into account.
Yeah, and if I may be the devil's advocate, we also have to remember about the costs. Sure. If this cost effective, how frequently we do have to see, because in theory we should see everybody, but in reality we can't. So we have to prioritize and to select the patients to see and when to see.
And just to be clear, it's really dependent on the variant and the region. There are different penetrances and in different regions with the same variant. We know that from Portugal and Sweden. There's a huge difference even if it's the same variant in the gene. So it's good to discuss with an amyloid center the frequency of checkups.
But I think that before considering, the genotype positive patient without a disease, I think we should think about the amount of patient with known sign and symptom of heart failure and cardiac amyloidosis without a diagnosis. I think we should move a little bit to those who are already in an over disease, but they don't have actually a diagnosis because they are not, probably they just didn't go through the right hospital, the right setting to get the right diagnosis. But I want to shift a little bit since the time is flying, but we discussed about the early diagnosis, but I think that now one of the key point, and again from a heart failure specialist perspective of a multivariety of treatment available, how should we handle in the next near future all these new available treatment that we have, stabilizers, silencers. In the next few years we'll have other drugs. Like should we have like an up-titration approach, a simultaneous approach? Should we decide what kind of patient should take one drug, another drug? How should we move in this? I think this is a really interesting and challenging therapeutic, I would say, dilemma. I don't know. What do you think?
Can I just, we have a question from the floor. Can we take that, prioritize that? Go ahead, sir.
When we try to diagnose cardiac amyloidosis in the early stage, it looks like meaningful, but I would like to know the rationale in practical life. We diagnose suspected cardiac amyloidosis even at the later stage in the elderly patient, and the earlier graphs show that the disease-modifying agents take time to come into effect. It takes about a year and a half, and we diagnose in our daily life quite a few elderly and in the late stage having a thick myocardium suspected of having a cardiac amyloid. Is it meaningful to go ahead and do whole of the algorithm of doing and then telling them that you have this, but you don't have anything. We cannot do much because the medication is expensive. It takes longer time to get it effect. What is the rationale in our daily clinical life? How should we apply this? I would like to know. Comment.
Yeah, I mean, it's a difficult question when to investigate and not. I mean, I think you should always ask yourself if you benefit the patient with a diagnosis. And I think it's perfectly fine to make a probable diagnosis without all the workup, just to understand how to adjust the heart failure medication. But then we also have the discussion on genetics and hereditary risk. Should we gene test all? If that could be debated. I think it depends on where you are in the world. If you're in an endemic region or if it's no family history and very elderly, the probability of a variant type is quite low.
Yeah, I think these are excellent points, and I think we all struggle with what you're saying, like which patients. So there needs to be some time to live. So if patients are in functional class 4 or they're in a wheelchair, I think these are not the patients we typically do all. So you can debate whether you would like to do some screening to see whether the patient, so do the bone scintigraphy, whether disease is there. And I think that also comes to the second point about genetic testing. So what we did in our amyloidosis referral center, so we test everybody, and then we were thinking like if there is no family history or if there would be anyone in the family who had already TTR, we would say like, okay, then we don't put them in that analysis. So we found 2 to 3% of the patients where we did find a mutation of the patients where we would absolutely not expect it. And that has quite some implication for the rest of the family, of course. So yeah, is it, so that would be 1 in 30, 1 in 35, where you do find a novel, where you do find the mutation for that family. So yeah, you can discuss whether that's cost effective. We do it, and I think most amyloidosis centers do genetic testing in all their patients, and I would be an advocate for that. But fully agree with your point. When do you stay? In the Netherlands, it's relatively easy because if patients are in functional class 3 or 4, it's not being reimbursed. So we don't really have that discussion, and also these patients are typically not referred. So for more general cardiologists, I think this is like, when should I refer a patient or not? And I think they're all valid points, and you raise a very important point there.
Thank you very much for a very interesting discussion. I apologize for not having enough time for the discussion, so we missed some very interesting points. But it's time to move on into the program, and you can talk to the panel and the speakers in the break if you have any further follow-up questions. Thank you very much.
Thank you very much to all the speakers and the faculty, and it's now my pleasure to introduce Professor Rossano, who is Professor of Cardiology at St. George's University Hospital in London. He's an expert in adherence in several cardiovascular conditions, and today he will speak about the increasing patient adherence and addressing polypharmacy in patients with heart failure. Please, Giuseppe.
Thank you, good morning. And I will try to reduce to the minimum the number of papers that published by Gianluigi, and as he did most of the work on this area, especially on the consensus papers. So I've lost my screen here, but it doesn't matter. These are my potential conflicts of interest. And we know that we need to treat all our patients with heart failure, at least with the 4 foundation therapies. And then, of course, then we have to add, as well represented in the iCardio guidelines, all the other therapies for comorbidities and devices. So that already takes our patients taking polypharmacy, because we know that polypharmacy is at least taking at least 5 drugs. Now, we know that we need to implement absolutely the 4 foundation therapy, because that improves life, and improves life, reduces events by 50% compared to an suboptimal use or to a delayed approach. And sometimes it's difficult to explain patients what a 50% reduction of risk is. But I think that if you tell to a 55-year-old that if they take all the 4 foundation therapies and that there's a priority of using them, then after 5 years, they would have gained at least 9 years of event-free survival. The same thing is that if that patient is 65, then after 5 years, they would have gained 9 years of event-free survival. So this is important because in order to increase adherence, patients have to understand why they are taking the drugs. Otherwise, if they don't know exactly what they're taking, then they will discontinue. And discontinuation is a big issue for patients with heart failure. This is a paper from Gianluigi, the 2 cohorts from Japan, America, and Sweden. As you can see, the discontinuation rate is at least 25%, and that is for the SGLT2 inhibitors, but it can go up to 33% for the MRAs and the ARBs. But of course, when we see the real patient, then this is the prescription. And these are patients I recently saw. It was in mid-November, and this was just page 1 of 2. So that patient was taking 22 different drugs. So some of those were needed for cardiovascular comorbidities, some others for non-cardiovascular comorbidities. We know that patients with heart failure have frequently other comorbidities, frequently diabetics, they have COPD, and they need to take other medications. But what do you think about a patient like that I'm sure you see in your clinic needed taking more than 20 different tablets every day? So the main issue in terms of adherence is related to polypharmacy. We have two different types of polypharmacy. One is the appropriate polypharmacy. The one is related to, let's say, patients with an ischemic heart failure, taking heart failure medications, and secondary prevention medications for the underlying ischemic heart disease. And then there is the problematic polypharmacy, the prescription of multiple medications, because whenever patients are referred to different specialists, they get all different drugs and that are added to the ones they are taking. And polypharmacy is not just due to the consultations with other specialists, it also occurs in hospital. You can see in this study here, the amount of polypharmacy increased from admission to discharge. And when you look at the type of polypharmacy, you see that the is not that much on the cardiovascular medications that are added, is mostly for the non-cardiovascular medications. And you may have to wonder whether all those medications are needed. Often patients take PPIs, they take alpha blockers, even just for a small IBP, and for which there's not a clear evidence for the alpha blockers, for example. So I think this is the big area where we need to focus in terms to reduce the polypharmacy. And we know that polypharmacy, hinders the optimization of medical therapy. This is a study on nearly 900 patients with heart failure that had some of which were not on polypharmacy, and half of them were on polypharmacy. You can see that those with polypharmacy at baseline were less prescribed guideline-directed medical therapy compared to those patients without polypharmacy. But also we have to take into account that those patients with polypharmacy were patients who were more complex in terms of Charlson index, and that more frequently other comorbidities. So it's a different balance in terms when we look at the polypharmacy between what is needed for the cardiovascular system and what is needed for others. Now, we know that the adherence to guideline-directed medical therapy is associated with a better outcome, and you see that those patients taking the 4 foundation therapies in prospective cohorts have demonstrated reduced mortality and reduced hospitalizations, and that in real world, the patients not receiving the standard medical therapy have a reduced survival. That is clear, and therefore we need to prioritize our treatments according to which is the treatment, the disease with a greater burden for that individual. Now, the first barrier, I think it's on us, and often physician inertia is the main barrier to full optimization of guideline-directed medical therapy. Now, this is a study from Steve Green in America, where they looked at the large database of 33,000 patients with heart failure. You can see that despite more than 80% of patients were eligible to receive the 4 foundation therapies, only 16% took it. So it's only 1 in 4 patients who were eligible were prescribed with guideline-directed medical therapy. So there is clear a barrier for the implementation of full medical therapy, and that is the physician. And other barriers, and this is a study that was shown yesterday by Phyllis Lindberg, and is a questionnaire we ran across Europe on heart failure, highly specialized heart failure centers. So don't think that these are centers that do not see patients with heart failure. These are very specialized heart failure centers in Europe. You see that only 12% prescribe in more than 90% of the guideline-directed medical therapy. In 23%, they said that they prescribe the 4 foundation therapy in 75 to 90%. And you see that 28%, only 50 to 75%. So there is still a barrier. There's a barrier, and also there are barriers that are perceived, that are not real. Now, you see here, there's Nicolas Gira yesterday told us very elegantly how we need to manage the hypotension, that very often we don't have to care about the fact that we measure low blood pressure values, and yet the hypotension, but not just hypotension per se, but the mild hypotension are regarded as barriers, as reasons not to start medical therapy. So we have to recognize that sometimes we fear something that is not there, and that prevents us from prescribing. And some claim patient adherence, but others, the creatinine increase or hyperkalemia that we know that can be easily managed, especially in patients without severely advanced CKD. Now, when we go to CKD, we see that we tend to withhold treatments, also even for moderate levels of eGFR. You see, this is for ACE inhibitors and ARBs and ARNI. It's even at 45 of eGFR, there is an increased discontinuation. And this is for the MRAs. You see, even a eGFR between 45 and 69 is associated with a significant decrease in prescription, and for triple therapy is even more evident. So we, first of all, need to be, whenever we want to address the adherence, we have to think at ourselves whether that is really related to adherence or that is related to inertia. The other problems here, as I showed you earlier, is related to the number of pills. And we know that the number of pills is not just in heart failure, but it's in all different cardiovascular diseases. It's associated with lower adherence. So lower pill burden is associated with a greater adherence. That is true in lipid-lowering therapy, in hypertension, as in heart failure. So we need to start thinking at deprescribing. So just to get rid of all the rubbish that our patients are taking, and that is not needed. I mean, it's not needed in terms of reducing hospitalizations, for quality of life and for survival. So first of all, when we deprescribe, we have to look at the drug-to-drug interactions, then at the potential for adverse drug reactions. Sometimes we use drug to treat a side effect of another drug, and this is clearly not correct. Then what is important is to prioritize a disease over the others. So heart failure has the highest burden of mortality and morbidity and should be prioritized over all the other diseases. And therefore, we have to create a sort of flowchart where we start with the heart failure medications, and then we identify all other diseases that may affect prognosis, but even quality of life, and therefore continue prescribing those drugs are appropriate. And of course, we need to start deprescribing when we start planning an end-of-life plan. Now, we've identified different ways of approaching deprescriptions in heart failure. So these are for example, the deprescription of drugs that may negatively affect cardiac contractility, like calcium channel blockers, some on the non-recommended beta blockers, but even with the beta blockers is the forced up titration sometime, and some antiarrhythmic agents that we still see often prescribed in patients with heart failure. Then there is a potential inappropriate prescription in those drugs that increase afterload. Patients with that have an antagonism of the drugs we're giving, let's say the short-acting beta-2 adrenergic agents, and they counteract often the effect of the beta blockers, so it's better to go with the long-acting in that case, and then also those drugs that increase the preload. So we looked at all these potential interventions, and we have highlighted 25 different ways of addressing this. Don't worry, I'm not going to go through all of them. So it's just to show you that, I mean, as a reference, if you want to look at that paper. So we identified 25 different ways of addressing the potential inappropriate prescription in patients when with heart failure. So when is therefore needed to deprescribe in patients with heart failure? We have to take into account some factors that should affect our decision making. One can be age, but that is not, mind you, chronological age. That is biological age. Sometimes you see it, that is very important. Then look at factors heart failure related, like the etiology, the type of the disease, the number of cardiovascular and non-cardiovascular drugs, the effect on physical capacity, neuropsychiatric status, and the impact on their social life. And then, first of all, you need to think at all potential drug-to-drug interactions and the number of drugs that may reduce the use of medications. And every time you see patients, you have to go through the list of drugs and see which drug you may discontinue, and because discontinuing drugs are not needed will increase adherence. Another possibility to increase adherence is using polypills. Now, I think we have to learn from other cardiovascular diseases the fact that we need to use the polypills. I mean, that has been shown in hypertension, has been shown in lipid-lowering therapy. Polypills do work. And this is one of the early studies that looked at the use of an ACE inhibitor and a diuretic, and demonstrated that patients taking a diuretic together with the ACE inhibitor rather than the two drugs separately had a significantly better adherence. And that has also been shown in patients with ischemic heart disease, patients with increased cardiovascular risk. You see that the use of a polypill, that including atorvastatin, amlodipine, losartan, hydrochlorothiazide, was associated with a significantly better persistence in treatment. And in patients with post-MI, a polypill that was using aspirin, ramipril, and atorvastatin was associated with a better survival. So polypill is another way of increasing adherence, and it may reduce events. And this has also been shown in patients with heart failure and in patients with hypertension. Looking at the different fixed dose combinations, you see that the different fixed dose combinations, you name them, so ACE, calcium channel blockers, ACE, diuretics, ARBs, calcium channel blockers, all of them were associated with a greater adherence and with reduced mortality. And we've recently, the QUADRO study demonstrated that the quadruple antihypertensive therapy was in a single pill was associated with a better mortality compared to a single pill. So there's it is very clear that single pill increases adherence, and being more adherent, patients will have a reduced mortality. This is the study that was recently presented at the AHA, where they looked at the combination of a single pill combination that was using empagliflozin, spironolactone, and metoprolol, and they looked at the patients who took the free combination or the combination in one capsule. Basically, they've encapsulated the three pills in one capsule, and it looked like that. And in that study, it was aimed to look at only at left ventricular function with a CMR. They demonstrated better left ventricular function at 6 months with the polypill compared to those patients who were taking the free combinations. Then the study was small, was not enough to demonstrate any effect on mortality and morbidity, but they looked at something that now it's very much on fashion, the win ratio, and they demonstrated when you put together the left ventricular function with a KCCQ, that was significantly improved, and death and heart failure events, there was a significant benefit, 70% higher chances to have a benefit with the polypill compared to the free drugs. Another way, and I'm glad we have here the man who tested the Nicola, the system that is well run in France, and it's I understand it's reimbursed, and it's each visit is paid, and where that demonstrated that an application that it can assist patients in the management of their drugs, but also in their daily management, is associated with a significant reduction in events. That is, I think it was the pivotal study, and they clearly demonstrated that the systems like these can work, and we have the evidence that the apps can work in improving the patient's adherence and may improve endpoints. Of course, we can't have one size that fits all. I mean, we have countries that are like France, where the system is rolled and where the visits are, in telemedicines are paid. We have other countries like, for example, Italy, Spain, where those visits are not paid. So we cannot just think at one single system. We need to find the different ways in different countries on how to optimize our intervention in order to improve patient adherence and reduce events. So that is based on patient factors, first of all, because patient factors and different phenotypes will need to be taken into account, on the effect on lifestyle, on gender, on the socioeconomics, but also on the route organization, whether you have prescribing nurses that can be used, like here and in the UK, or where you can have the pharmacists, and pharmacists are key, in, at least in our system, to increase patient adherence. Other systems like digital health, and also the e-prescribing. So I don't think we can just suggest one single model. The two keys are de-prescribing and the use of a single pill combination. Then all the other systems can be put together in different ways. So the adherence of medical therapy is inversely related to the number of prescribed drugs. The first step to improve adherence is the prescribing. So whenever you see patients with a prescription like the one I showed you, just think the prescribing, the prescribing, the prescribing. Then the polypill can be useful, whether it's through an encapsulation or a single pill combination. And what is important is we need to adapt our strategies to what we have and to try to maximize our resources, whether those are the pharmacists, whether the nurses, whether the digital. And so there's not a single silver bullet. Thank you very much for your attention.
Thank you very much, Giuseppe, for the great presentation. Is there any question from the audience? Otherwise, I do start. We have a few minutes for a few questions. So you were speaking about single pill combinations, right? In the setting of heart failure, would you use such an approach for initiating therapy or rather as a replacement therapy?
I think both. Mm-hmm. There are some fixed combinations you can roll out immediately. I mean, let's say you have patients with heart failure, you don't have an you don't have an echo. But you know that there are SGLT2 inhibitors and MRAs that work all across the left ventricular function. So you just tell your GPs, say, look, when you refer them, start them on this combination. Then there are others that are substitution therapies. So once patients are being optimized, then that is especially for the beta blockers, the ARNI, the ACE inhibitors, because otherwise you need to change frequently the dose. Then you prescribe the single pill combination. And of course, each single pill will need to have all the dosages that are present in your market. So if you think of 3 pills with, of which only one has 4 different dosages and one has 1 dosage and another one has 2 dosages, then you go already for 19 different combinations. So, and they had to be on the market because in order to be approved and as a fixed dose combination, then all dosages need to be on the market so you can switch and change the beta blocker, the ARNI, or the ACE inhibitor, and the MRA. So, for example, so it's there are different possibilities. The other possibility is that your pharmacist does the encapsulation, and that is also.
What are the pros and cons of encapsulation?
I mean, it's a human mistake.
And it's
that is something you always have to take into account.
And the pill is bigger, right?
Yeah, and it takes time, and there is an additional cost from the pharmacist. So the single pill combination, and then it's the issue sometimes is related to the different type of drugs that are used and the switch from brand name to generic, or even from generic to generic, that may have a different impact. Also on size.
Right. And would you expect to start with a single combination with 2 components and then switch to 3, or would you consider starting directly with 3, considering also that many patients have comorbidities and therefore they are already receiving some background?
No, I think it depends when you see those patients.
Yeah.
Because if, I mean, the message should be for the GP, for the practicing cardiologist, until they don't have a clear definition, but they, for example, they have an elevated NT-proBNP, then start SGLT2 inhibitors and MRA. Then once you've defined the diagnosis, you have your left ventricular function, you've started your foundation therapy, then the triple combination or the quadruple combination can be useful.
Okay. Any comment, question? No? So please, Nicola.
So thank you so much for this talk. Don't you think there's a huge overlap between polypharmacy and actually frailty? And polypharmacy is part of frailty, right, in those scores. And my feeling is that actually we have only touched the surface of this so far. And patients from nursing homes with 25 medication are quite different from, patients coming to your consultation with 25 medications, right? So there's some kind of difficulty assessing this. And I have in mind a paper our team published in New England Journal of Medicine in nursing home, deprescribing antihypertensive therapy and showing, it does not change many things. So my personal take on that is I try to see whether heart failure is the main problem of the patient. And if he has a list of major other problems, then I don't overdo it for heart failure. That is very not evidence-based, and it's just a way to cope with daily life, right? But what's your pick on that?
Yeah, no, of course, frailty is a big issue, and the polypharmacy in nursing homes is very high, but that does not affect adherence. Affects the frailty, but it's not the adherence, because usually the patients are given the medications, are checked. So that is an important issue. But we have large space for the prescription. You were mentioning yesterday the alpha blockers. I mean, 30% of men that you see are above the age of 70 coming to our clinic, they have an alpha blocker. And then people are afraid of hypotension. And so that is one. How many patients are on PPIs and they have drugs that are not absorbed, are not acid, and they're not absorbed through the stomach? How many patients are taking the supplements for the guts and that are not needed? So it's I think it's a big issue, and it's with frailty. And you're right, but it's I think we need to go. And by the way, that was a 67-year-old lady. So it's and you can see how many tablets she was taking. So it's a big issue, and we're just scratching the surface, as you said.
Thank you so much, Giuseppe, for the great talk. And so we move on with a coffee break.